place to be. So good evening. My capstone project involved adapting a mindfulness curriculum for telehealth delivery in order to increase access to services for the students on our waiting list for mental health care. So why was this particular problem chosen? I work in an urban hospital-affiliated school mental health program in New York City. Our students are largely from minoritized groups who are hit disproportionately hard by the COVID-19 pandemic. As you can see from these headlines, COVID drove a mental health crisis for children at the national level. Earlier this week, there was actually an article in the Times about increased emergency room visits for psychiatric crises in children, so it remains an ongoing issue. Our program felt this particularly through our increased waiting list for services and an overwhelming need to help children with their trauma and emotion regulation skills. The project was implemented in the school-based mental health program, and that's the subspecialty program in the Child and Adolescent Psychiatry Department at New York Presbyterian. We serve over 10 public schools in Washington Heights and Harlem, and we provide therapy and psychiatric care. The majority of the children we work with identify as Dominican American. I chose a mindfulness-based intervention to target the emotion regulation needs of students waiting for mental health services. Mindfulness has been practiced for thousands of years, initially being popularized largely by Eastern spiritual practices. Mindfulness has been secularized in the West and now translated into evidence-based programs. Mindfulness-based interventions for children focus on things like psychoeducation about emotions, breathing exercises, and cultivating a non-judgmental awareness of one's thoughts, feelings, and senses. By increasing kids' awareness of feelings, we can reduce emotional reactivity. I think one of the quotes from our Mind Up program, "If you can name it, you can tame it," kind of sums up that. So Mind Up is an evidence-based curriculum. It's designed for in-school delivery. Like other mindfulness interventions, it's been found to be feasible to implement and well received by students. So I chose it for its feasibility to implement for a large number of students at the same time. Constraints. In other words, the immediate environment directly facilitates and/or constrains clinician behavior. So that means I looked at what would increase clinician participation in the intervention and what changes at the organizational level would need to happen to facilitate those changes. I chose intervention mapping as the overarching framework to examine the individual and organizational barriers and facilitators for implementation. Intervention mapping is organized as a series of iterative steps that allow for modification along the way based on feedback. So intervention mapping has the benefit of improving adoption in real-world settings because it allows for the incorporation of suggestions that emerge out of our ongoing needs assessments. In this way, there's a higher likelihood of the program being not only theoretically sound, but also successful in its implementation because it was adapted based on local needs. The TDF, or the Theoretical Domains Framework, was used to examine those individual level barriers and facilitators that impact clinician behavior change. The CFR, or the Consolidated Framework for Implementation Research, was used to examine the organizational level barriers and facilitators that affect implementation by our clinicians. And then I linked the barriers to strategies in the ERIC, or the Expert Recommendations for Implementing Change, to facilitate improved implementation outcomes. There were several facilitators, mostly at the organizational level, for this intervention. In terms of Mind Up itself, we found that it was strong in trialability. In other words, it was compatible with clinician beliefs about mindfulness-based interventions in general, simple to implement due to the training website and pre-developed curriculum. The idea of introducing a group to meet the emotion regulation needs of students who were not yet able to access care fell into the CFR domain of tension for change. So this model was seen as a way to reduce staff burden from taking on additional cases, while also increasing client access to services. And finally, the project fell into the CFR domain of readiness for implementation or access to knowledge and information. This is because our school-based clinicians have become really proficient in delivering many evidence-based interventions via telehealth during the pandemic. As I mentioned before, the barriers that came out of the needs assessment were then mapped with intervention strategies from the ERIC. So I'll quickly go through each of these now. The first barrier, which was limited staff knowledge of the Mind Up program, fell under the TDF domain of knowledge and skills. as our practitioners were not familiar with MindUp. As my strategy, I created a Spark video, which demonstrated the evidence base for mindfulness-based interventions and how it aligns with our population needs. This choice of strategy is in line with implementation research that suggests providing evidence to promote buy-in to staff prior to implementing a new program. The second barrier relates to complexity. There are concerns among providers that adapting the curriculum to meet the learning, cultural, and trauma needs of our students would be difficult and time-consuming. Facilitation groups in education and mental health have been used to increase confidence in delivering new material, possibly due to the knowledge sharing and advice that happens in these groups. Next, there was the very real barrier of available resources in terms of staff time. Therefore, my strategy was to increase awareness of incentive structures and staff roles, which means I worked to identify staff with role flexibility beyond direct one-to-one individual patient care. And finally, because the group was offered via telehealth, both to reach students across multiple school sites and due to the ongoing pandemic, it was crucial to understand the technology needs of families. We know that there are technology deserts and disparities with the students we work with. And so I created a technology assessment at intake to better understand families' needs, their feelings about the use of technology, and troubleshoot ways to have them participate. So what does this all look like in action? So the method was all of the clinicians in our school-based mental health program were recruited to complete a mindfulness program awareness survey that I developed for the project. They completed this before and after they were provided the Spark educational video about MindUp. After that, I recruited co-leaders for the group based on the strategy of understanding role flexibility. Those providers who agreed to co-lead the group completed the provider implementation survey that I created to gather information about their sense of comfort in adapting MindUp and their feelings about being supported in doing so. They completed this measure before and after the 12-week facilitation group. In terms of students, I recruited students in grades 3 to 5 from the school-based waiting list. In about a 2-week span, 14 students were referred and 6 caregivers completed our screening process and enrolled their child in the group. All 6 students also consented to participate in the study. They completed a baseline perceived stress scale, and at the end of the group, students completed the perceived stress scale again, as well as a child satisfaction survey. I know I went through some of the pre-intervention adaptations to MindUp, but I want to highlight a couple of other adaptations that were made along the way. There were a lot of sensory activities that were in the MindUp curriculum, and so doing this via telehealth, we had to address this by mailing boxes of sort of the pertinent items to our participants. We also had varying academic levels in the group. So that led us to change some of the more language-dense portions of the curriculum to meet the needs of those students. In the future, we're hoping to add a pre-group caregiver orientation with the hopes of increasing uptake. Due to the importance of practice or homework in mindfulness-based interventions, we're considering incentivization for homework, including recorded practice sessions by the group leaders, and considering a drop-in model to address some of our attendance concerns. Some of the key takeaways from this project. I think given the inconsistent attendance for several of the group members, we need to problem solve additional ways to support families that are overwhelmed by neighborhood stressors to be able to participate in these groups, particularly as those are the families that we really most want to target. In order to keep the group sustainable and able to scale up, recruiting providers with more flexibility in roles, including trainees, can be a helpful strategy, particularly if facilitation groups also incorporate more training. In terms of increasing staff buy-in, I think a move towards modeling versus passive education may be more successful. For instance, after the group began, we had even more interest in referrals after clinicians were seeing this in action. And finally, we should note that the group was well liked by students, and the adaptations that we made seem to very much support their unique needs. So what's next? We're in the process of planning for additional cycles of MindUp in the clinic. There's really big interest across not just school-based, but some of our other subspecialty clinics. We're doing additional data collection to refine our adaptations for sustainability and fit. I've already started disseminating findings to clinic directors and schools. If you're interested in my complete reference list, please feel free to scan the QR code. And then just briefly on a personal note, I think getting to implement a project in real time in a real world setting during a period of great need was a really amazing opportunity and shows the power of implementation science and social work. So thank you.